Sorry, everybody, that you're having to wait. There are meetings going on top of each other, and we do have people that supposedly are on their way. We changed our quorum last time from 11 to 8. So hopefully we are 1, 2, 3, 4, 5. Now we're 2 away. Hey, Jody, thank you very much. Okay, everybody, let's call everybody. Other people need to go places, and so we have a quorum, so let me officially call the meeting of the House Public Health Committee to order, and we're going to start really quickly, and I'm going to call up House Bill 565 by Representative Smith.
Okay, thank you, Madam Chair. It's always good to see another member of Judiciary Non-Civil as a chairman in another committee, so thank you. I bring to y'all House Bill 565. As I recall, this committee was favorable to this bill last session, and so I bring this to you here today. I would note in my limited time that I have with y'all as y'all trying to get home that if the committee is favorable to it, that we propose an amendment here. We found with some updated data since last year that what we had proposed in the bill that it would, with the inflation being what it is, food prices going up and whatnot, that we would look at actually increasing the TANF monthly benefit to 30% of the federal poverty guidelines. And so what that, yes. That's okay. Oh, I'd do whatever the Madam Chair tells me to do. No, thank you, Madam Chair. And so just to look at the current policy for a family size of just one, you're looking at the maximum family grant of $155, with a family size of two, $235, and with a family size of three, that would be $280. And so we feel as if we move this benefit to the 30% of the federal poverty guidelines, basing it off of that, it would not send too much of a shock. It would be a reasonable response to what we've seen with the inflation prices being what they have. And just so I know a lot of y'all are on the Agriculture Committee, and I thank y'all for y'all's service. We have not realized the full effect of food prices going up yet. That cost has not been fully borne by the consumer as of yet. And so I'll just reiterate as I close here before any questions, that one of the main reasons that I took this on and decided I wanted to become a champion along all of the others that have worked so hard on this is we basically have scenarios now for people to qualify for TANF. They're basically having to sell their car to even be able to buy diapers for their children. And to me, I know Madam Chair may have been here when the last time it was increased, but when you're having to make a trade like that, the program is broken, and we really need to focus on getting these folks the support they need. So with that, Madam Chair, thank you.
Questions for the presenter? Okay. Who? Hutchison? Shirley?
Okay. I just wanted to say thank you for bringing this bill. My first job out of college was defects in 1993. Y'all don't do the math. I started off as a food stamp caseworker in 93. So I was very familiar with the TANF program, and it has not increased since then, since 93. So this is, and I just want to reiterate that there's still a lifetime maximum. You can't do this forever. It's still very limited on how many months they can get this. So this is not a long-term thing. This is still temporary assistance. I just wanted to make sure everybody was clear about that. And thank you for bringing the bill.
Thank you. And if y'all like acronyms and trying to figure out what they mean, that T stands for temporary.
Temporary.
Representative Reese, you want to make a motion?
Well, I won't
No,
make
I'm
a
teasing.
comment. Then I
I'm
was going to make a
teasing.
motion. Well, I don't want us to linger on this too long. This is a great thing. This is helping Georgians where they need to be helped the most. And I just want to thank you for bringing this bill, and thank you for, you're a stand-up guy already, and you know that. And I don't have any bills before your committee. I'm just speaking the truth. Just speaking the truth. But I appreciate you for thinking about everyday people with this here. And Madam Chair, if it's okay with you, at the appropriate time.
Let me tell you, anybody in the South that grows up with a double name and it's not a girl, Tyler Paul has had to fight some fights.
Thank you, Madam
I
Chair.
think you were the first person. I grew up with Clara Jean and Sarah Beth, and so next door neighbors, and so I'm just giving you a hard time.
I appreciate it. I
Rep-
love getting ribbed about it.
Representative Lott. Representative Lott.
Thank you, Madam Chair. My question, I may have just been answered by my seatmate here, but so have you explained to us what where the amendment is that you're considering?
Yes, ma'am. Not yet. I wanted to describe that. I know there's some particulars that we'll get with Legislative Council on to make sure we craft that in the right manner. And I've got to phone a friend coming up to help us with that as well.
Okay, so right now, the changes we're making is we're going from a maximum of 48 months to 60 months.
Yes, that is correct.
Okay, and it'll start on July 1st and 1st of 2023. I think we'd have to change that
Yes, that is correct.
that date to whatever legislative council, so that needs a change. Okay, the other major changes are that the resources an applicant have shall not exceed $5,000, and that excludes the value of the car.
Yes, yes, that is correct,
And
Madam
that
Chair.
change to 5,000 is it went up from
I had to go back
20
and I believe that's correct.
2,500 or 2,000? Huh? $1,000 instead?
That's what it is now, which is extremely low.
$4,000, okay. And the car couldn't be valued more than, and then now you can have up to $4,650 of a value of a car?
That is my understanding, Madam
Because
Chair.
before, maybe that's what I was thinking, could be worth $2,500, which you driving a $2,500, you're basically driving a clunker.
Correct.
And if we want these people to be able to try to get educated or try to go to work, one of the major things they need is that car. And if they were selling it to buy diapers because it was over the amount, they're sort of just in a deep hole. And, you know, how do you take a baby to a doctor or go to a job when you don't have transportation? It's one of our problems in this country is transportation when we're dealing with people on any kind of assistance. Okay, you go ahead now. Do I have a motion on the bill? Got it.
I just wanted to add too that, you know, growing up in the African American community, there were some very strong women with double names that influenced lives like mine, like Shirley Jean and S.C. May and Carrie Lou. There's some very strong names with double names. But
Yeah, well,
at this moment, I move that the committee do pass House Bill 565 LC 520298S.
Okay, and then I've got a second on it. Okay, now let's go to what your amendment would be.
Yes. Let me go back. So this would be to increase the TANF monthly benefit based off of 30% of the federal poverty guidelines would be.
And where is that specified?
Madam Chair, I was going to defer to legislative council on where this would best be placed in here.
And to the committee, I apologize, that's coming this form. I would not normally accept it so late in this thing, but we're running out of days. And this one is very important. This bill is extremely important that it has a chance to make it out of rules and to cross over. And so I made the exception this time, and I think everybody would agree with me. It's worth doing this on the, what do you call it, on the lamb, whatever. On the lamb, whatever they would call it, to let this have a chance to get out. We're waiting on legislative council.
Checking to see if there's another code section. But
Okay.
right now, I'm leaning towards in subsection B, but I want to make sure we don't have the code section. Separate code section.
Well, and we were on a thank you with a member leaving and saying thank you to everybody that makes a difference. And I'd like to echo that our legislative department and legislative council that writes these bills, I mean, they are churning out legislation at a masterful rate, and I don't see how they keep up with all that we put forth for them to do.
Madam Chair, I'm being summoned.
Okay.
If you need me to wait, I can wait, but you just tell me when I'm free to go.
Okay?
I trust the will of this committee. This is one of the
And you
committees I
want
can
it to be a
trust.
third of the?
30% of the federal poverty line.
Okay. Unless I have great objection for somebody on the committee, we'll take over for you. We know what you want,
Okay.
and you'll have to trust us.
I trust y'all with
Okay.
everything in my being, Madam Chair.
Okay, where it needs to go. Okay, let me tell you where it needs to go. Right there, it's gonna go on line 13, and we'll add what it is and make the corrections. And before we, go ahead, go.
I can wait another minute if need
Okay,
be.
do you wanna read it out and tell the committee?
Line 13.
Line 13,
Line 13, after thereto period,
okay,
we can insert the language there,
okay.
which is
Which would be, Let me pull that back out. To increase, it would be to increase the TANF monthly benefit to 30% of the federal poverty guidelines.
How would you like it to read, to legislative council? Yeah. Ms. Wells, do you have anything while we're waiting on them to figure this out?
Yeah.
Okay.
We also have somebody else to testify as well. So.
Okay, are you testifying in favor?
In favor, yeah.
Okay, is there anything, say who you're with,
Yes. Okay.
right there.
My name is Callan Wells. I'm with HERE's the Georgia Early Education Alliance for Ready Students. And we brought families to the Capitol today for Strolling Thunder. That's why I'm wearing that t-shirt to present in front of you. And I actually wanted to read a couple of quotes that they wrote to legislators. Thank you.
And we don't allow any deliveries here at the Capitol. It's forbidden.
I promise you, no one wants to deliver less at the Capitol than me. But I did want to say that she has a double name, so
Oh, great. What are you going to name her?
Alice Rose.
Oh,
Yeah,
nice.
so,
Well, you
thank
know,
you.
in Parliament, nobody can die in the Parliament building.
Okay, I
That's
promise
when
not to die or to deliver today.
You know,
But anyway, I wanted to read a couple of quotes that I think really speak to the need for this bill. And these are from families who some of you may have met with at the ropes today, families with young children who were here to advocate on behalf of their families. So the first one, it's hard being a parent when you don't have the support from your community family or your legislative branch. It would be great if you all gave out more stipends to parents with small children. That would give us time to spend with our kids. Even though we have to jump straight into mommy mode, we hardly ever have time to do what we want with our babies, like read a book or take them out for a walk. We don't get much of this time because we're working 5 days a week and having to go home tired. Most of our time goes to working a job. Family support is much needed in today's society due to inflation and the way things are nowadays. The hell that we have to go through to get help, it shouldn't be this hard for us. And then the second one, sorry, the baby's pressing on my lungs. It's been challenging the past few years to make ends meet. My husband and I work really hard to put food on the table and pay bills. If only we could have a little leftover to save for my children and our futures. I am working part-time to be able to take care of our son, to be able to take our son to his therapies and or appointments and be able to watch over my toddler. Last year, I had a full-time job and saw myself working to just pay the babysitter most of my salary. It feels like each day we are faced with another financial obstacle, whether it's paying for car and home issues, bills, food, school events. This has been definitely an emotional, mental, and physical struggle to keep up with. So just wanted to share their voices, and we appreciate this bill. And I'm going to invite.
well, okay, and if you'll be very, very short, because we have several bills afterwards. I don't mean to, I'm sorry to have to hurry you along.
Yeah, I'll keep it short. I'm Rainey Jeske. I'm with ISDD, Innovative Solutions for Disadvantage and Disability. We serve the vast majority of the TANF recipients, which are child only, and that's grandparents who are raising their grandkids. They are outside the foster care system. They get none of those supports or services, and so TANF only, child only TANF is a very important part of how they can manage to raise children on their social security checks, because folks, that's what's happening. So thank you so much for any little thing you can do to make it easier for the grandparents. This is representing about 100,000 kids in Georgia being raised by the grandkids. Thank you.
Thank you for bringing that up. We expect a lot of our elderly, and yet they're one of the most maligned and neglected and abused part of our society. elder abuse from all the things are on the rise, and yet we have a few gems who, no matter how hard it is on them, step forth to raise their grandchildren. Thank you for your work you do on that. Are we ready? Okay, let's tell us what the amendment looks like. Everybody got it? It's on starting on. Are you still starting on line 13?
Okay, on line 13, after thereto, semicolon, provided that such monthly benefit assistance shall be increased to 30% of the federal poverty guideline.
Okay, could you read it again, please?
Yes. On line 13, after thereto, semicolon, provided that such monthly benefit assistance shall be increased to 30% of the federal poverty guideline.
Is there anybody question about it from our legal part on the wording on that? Any questions, comments? No? Okay, thank you very much. And then we would
And
need
then
to change,
Line 16, 2023 to 2024.
right, in July 1st, that's right. So, okay, that would be the amendment. No one has any comment about it? Okay, can I have a motion on the amendment?
So moved.
Got a motion? Second? Got a second? Everyone in favor of the amendment as read by our legal counsel, say aye. Aye. Anyone opposed, no. Okay, the ayes have it. Now we're back to our bill. Is there any further comment on the basic bill? Okay, here we go. We have a motion and a second. For the passage of House Bill 565, now as amended, which will travel as a sub. So everyone in favor of the passage of House Bill 565 as amended, which will travel as a sub, say aye. Aye. Anyone opposed? No. Okay, the ayes have it. Thank you very much. This is a significant accomplishment. So, or like that. So, okay, moving on. Where's my thing? Here we go. Okay, coordinator. Okay, let's see what we've got. Okay, let's go with, okay, Representative LaHood, you've got a long way to travel. I think you may be the farthest away at this point, so you're recognized for House Bill 1335.
Thank you, Chair Cooper. And I just want to start and I'd like to start and thank Chair Cooper for working with me on this bill, along with the department who's in the room and the Georgia Senior Living Association, as well as other provider associations that are here. And this is a bill that's come a couple years, I guess 3 years now, after some pretty transformative legislation, House Bill 987, that Chair Cooper sponsored in 2021, I believe. So we've had a few years now to live with that and the rules that resulted in the transformative rules changes for the senior care industry. This is assisted living and personal care homes. And so after living with those for a few years, we've just discovered some ways to make some small tweaks to find some efficiencies for providers that will become beneficial to the residents that we serve by allowing a provider to allocate their staff in the building where they're needed most. And so what we're doing for the first time ever is the department will recognize a medical alert system, the presence of a medical alert system in the building, wearable devices that a resident can use to alert the staff that are on duty that there's an emergency or that there's a need on a particular floor or wing. When those medical alert systems are in place and approved by the department, it will allow the staff to float, give them more fluidity in the building. And the other thing it does is allow the credentialed staff, namely certified medication aides and licensed nurses, to float in and out of the memory care portion of the building, back and forth to the non-memory care portion of the building, as long as there's at least 2 trained caregivers in the memory care living area at all times. And so we're not reducing any staff, we're not changing staffing ratios, we're just allowing some fluidity so that the provider can allocate their staff, mainly their credentialed staff, where they're needed most. Because different times of day, the needs change. So I'll take any questions if there are any.
Okay, well, I just want to have a say about things. I'm very passionate about this, and those of you that paid any attention, we had quite a discussion and a route of stopping bills to reduce. We have a bill that says you have to have 2 people in the memory care at all times. There was a movement by some providers to want to change that. It took us 3 years of fighting it till they said, oops, we give up. So, thank goodness. I hate to put it that way, but it's true. That they realized that the advocates, led by really great leaders, and the fact that I was going to back them up, that was not a way to treat our seniors in memory care units. Now, this will affect, these are in assisted living and 25 bed or
Personal
more.
care homes,
Personal
correct.
care home, the larger care homes. These are not, Medicaid-related nursing homes or anything. These are private facilities. When we did assisted living back in years ago, we thought that the people were going to move to assisted living facilities when they were 75 or 72 because they didn't want to mow the grass anymore and they wanted easy living. That's not what's happening. People are moving to them when they're in their late 70s or in their 80s, and really sort of 80 on. As most people will know, that by the time you are 85, you've got a 1 out of 2 chance of having dementia symptoms or being in some kind of dementia. And when you're in that 80-year-old stuff, you're beginning a lot of times to move toward that. And so the need for care and oversight has not increased, or the realization that people need to know. It's almost like these are pre-nursing care facilities. They're no longer, you've got a gym and a swimming pool that's heated and you can go out to dinner and eat. They're serving a very different kind of population across our state. And so they're a need to be very protective of what we're doing. On the other hand, the realization that staffing is a real problem. And how do you do this where it's best for the seniors? One of the problems we've had over the days are people falling and being left on the floor for 6 hours, 10 hours, and then dying from not being picked up, and with the call lights going and nobody answering. So let's get this straight. Where's Joe? Okay, Joe. People will now have, the people that run these facilities will now have the option of staffing the floors with 2 people, live human beings, or we can go down to 1 staff member if everybody in their facility wears a alert system. Alert system dictated and by the people in our department in the rules that would not only alert somebody in the system, but if it went unanswered, it would go to 911 or to a family member or somebody outside. So somebody will answer the call when a person feels like they are in extreme need. They got it? Okay.
Yes.
So
we're allowing technology to come in and
to go.
supplement and be an added layer. And like I said, for the first time, this will be recognized by the department, and because there's no requirement to have these systems in place right now.
And still not required, optional.
It's optional between staffing.
Right. Still not required, but will certainly now be an additional incentive to have those.
The only thing I would add, Madam Chair, is anticipated that the device would trigger when someone falls.
Right.
That you don't have to hit. I mean, that was what we talked around because of what you stated. Because if you're not near a call button or what have you, then it would trigger. So.
Right, because
like
often.
an Apple Watch does, if you're all familiar, or
Right.
there's wearable devices.
This is not perfect. I mean, technology is changing, needs are changing. We are trying to find a way to administer the best kind of care in this in this industry and with the changes that have come in that industry. And, you know, in places where you have an apartment, often your call light is in the bathroom. Now, nobody dictates that the only place you can fall is in your bathroom. If you fall out of your bed or on the way to the kitchen, where I'd probably be going in the middle of the night to get a glass of water or something to drink, it wouldn't be covered. But with if a owner chooses to go this route, then that person would have a way of alerting the need for care away from that basic wall-held unit call center. And hopefully technology will continue to improve, and we can find even, you know, better ways rather than trying to wrap our elderly in bubble wrap and, you know, to make sure that they don't fall and that they're taken care of. Okay, and so we got that clear. Joe, does the Southern standard still hold like it does in the nursing homes, where even though it's down to 2, I needed to clarify this, that they still have to meet the standard of needs of care, like if the needs of how many people they had on a unit.
Yes,
Can you
ma'am.
explain that,
There's
please?
still in existing, in present statute, that at the end of the staffing ratios, I think in several places, it states that the needs of the client have to be met regardless of the ratio or of these 2 at all times. So if, you know, if there was a complaint, you know, that all has to do, particularly in memory care, with the acuity of the
Right.
folks who are there. If you have a lot of folks who are very needy, you may indeed need more staff. If you have a lot of folks who are on the look, you know, they have good acuity and maybe it's not as much dementia as that, or a mix, it may not be as much. So that's why that's there, and certainly when they investigate complaints, they're gonna look at the standard versus what the complaint is, and not necessarily, they're gonna look at
Right.
you know, they're gonna look at that, but it's also, was there enough staff to accommodate the acuity level of clients who were present?
Correct. So regardless of the required minimum staffing
Right.
ratio, the provider is still responsible to meet the needs and safety and well-being of
I
the
just wanted to
resident.
make sure, as we talked in this committee, knew that, and it was out in public, and anybody listening to it because the public is becoming more and more concerned about what's happening to their loved ones, and as they should be, and I hope more people realize that if they put a mother or somebody in a nursing home, they can't just walk away and think that everything is fine, that they need to, you know, pay careful attention and visit and, you know, really check on what is happening to them. Okay, we have questions. Hutchinson.
Thank you, Madam Chair. I just have one quick question. Are we adding the requirements, or are we changing something that's already in here? The staffing requirements.
We're not changing staffing ratios. We're just, what it essentially does is, if the provider chooses to provide a medical alert system as approved by the department, it just allows a little bit more fluidity.
Gotcha.
Of how the staff, you know, how their time is allocated around the building.
So the language about having 2 people or 1 people on site, that was already in here?
Correct.
Okay, thank you.
Okay. Representative Howard.
Thank you, Madam Chairman, and thank you for the bill as well. It sounds like this is a win-win for the business owner, the patient, and the family. I would be concerned about the cost of these items, these medical alert systems. Is there a cost that's going to be passed on to the business? And what is that cost, or would that be something
Right.
that they should be concerned about?
Great question. And so right now, there's over 450 some odd, you know, assisted living communities that are licensed in the state, and even more personal care homes, and that could be impacted by this legislation. And out of those, I would say the majority probably already have a medical alert system in place. I think this will incentivize enhancing those systems. To include wearable devices that provide more communication to the staff and even people outside off premises, like an adult child. And so, yes, I believe this will incentivize more innovation and implementation of technology in the building. But the cost, most providers don't add a fee to provide these kind of technologies now. And yeah, I guess they could, but most don't. These are private pay situation, and so that will be between the resident and the provider.
Joe, did you want to add something?
I think the chairman hit on it. The big difference is most of them have this in place, as we were talking about with the button, right? They have
Right.
2 buttons in a facility, and so we're just talking about adding a wearable device, which most likely could be incorporated into their existing system, as far as we still go to probably the same place, might even be part of the same system.
Right. The modern systems can send, when a call is triggered, it can send notifications to a smart device or a master station at a nurse's desk or a variety of ways.
But Joe, we will have the department where it will either go to 911 or
I mean, it says in there that we will make sure it's an effective system, so I hesitate to provide. but
Too
we
much
do
about
that
it.
Through administrative rule, and that is the other big difference. We do not survey this as a requirement, those systems today at all. So those that exist, we don't check for effectiveness or anything because it's not in any of the statute or administrative rules. So this really gives an additional oversight by the department to that system where
Right.
it's being utilized.
Okay. Representative Howard, you have another question?
No, I'm good. I'm good. The part that you just cleared that up for me on how you guys will be the ones that determine which system
Well,
that they use.
and to be truthful, let's just be very truthful. And some of these are owned by out-of-state, what do they call them? Wealth management. Manage things like that. And I would imagine they will expect whatever. If it's a wearable something, they will expect the client to pay for it, just to be perfectly honest. And some may decide that this is more economical if they provide it and it, and have control of it. It will be up to them. And if they don't want to do this, they will stay with the same staffing requirements that they have now.
Okay.
Correct?
Yes, Madam Chair. But I suspect there are other benefits. I mean, there's probably a liability aspect for the facility that's a gain, I would suspect, because falls are identified more timely and all the things. So
Right. I would.
there's a good chance that this could be done.
That's right. I would say this will definitely incentivize a provider to implement these safety measures and that the technology will bring.
Representative Reese.
Thank you, Chairman, for this bill. Question of clarity here. I'm trying to make sure I visualize this properly in my head. So you have to have 2 on-site administrators at all times, right?
Well, 2 on-site administrators or 2, I believe is it responsible caregivers?
Okay,
Is that how it's
okay.
worded?
So
at least 2.
at least 2.
An administrator is one criteria that would satisfy that too.
Okay. So if I have a one level, 1 floor facility, 2 people that meet that criteria has to be there. If I have a 2-level facility, if I'm reading this formula right, it's 1 per floor, 1 per floor, right?
Right.
And
So-
if it goes up to 3, then I still have to maintain 1 per floor per this statute here, right?
So current rule requires each floor to be staffed at all times.
Okay.
And so what this bill will do is when there's this approved medical alert system in place that allows the resident to
Well, I get that.
trigger
We
a
would
call,
use-
it would allow the staff assigned to that floor,
Yeah.
to float to another part of the building temporarily to, retrieve something from the kitchen or the supply closet or
Yeah, that's not my concern.
Yeah.
I just want to make sure we didn't get confused in here because we kept using 2. But if it's a multi-floor facility, it may require more than 2 because you have to have 1 person each floor. So if you got 3 or more floors, and with that in mind, 1 person per floor, adding these devices actually give you greater coverage because 1 person can respectfully manage probably monitor 1 room at a time. But now you're kind of, in essence, using technology to monitor multiple rooms.
right. Yeah, I would call this a bill that's just adding another layer
So it's
of
enhancing.
safety.
It's enhancing the care for the people in the facility.
Absolutely.
So I appreciate that. Thank you.
Joe, now I'm getting confused. Is it only out in the general part away from, is Teddy right, is Representative Reese correct in saying about the floors?
It without the the device, that's
Right.
accurate, to my understanding. But with the addition of the wearable device, it allows for them to move between floors. They don't have to be stationed permanently on their floor as rule calls for today. The additional item is, this is placing that in statute. Previously, we had it in rule. So we were operationalized, so this was some of the discussion is what is, so now it's clear when we do that.
Right, and the reality is, in real life, certain times of the day, when there's a meal going on or an activity, you might have 10 residents that live on a floor. 9 of them might be in the dining room at one time. 1 is left on the floor. If that resident has a medical alert system that they can use to access staff and they can return to that floor to meet that need timely, then that's what the department will allow in this situation.
So you can move around the building. However, you still have to have, that person has to be in the building.
Oh, absolutely.
So you
Yes.
can move, so if you got a 3-story building, two of them may be on the first floor at one time, while the second one's on the second floor and no one's on the third floor. But you're still meeting the criteria because you have the monitoring system and you have 3 people in the building per the statute because you need at least 1 person per floor, right? Am I
Yes,
reading that right?
That is right.
Okay, all right.
We had the coverage from the big bill for years ago where we still have, they're supposed to have a nurse.
There's limited nursing services, and the present statute addresses that, and it also has this new language mimics that in the building, and it's specific in statute for in the building, it says that for the nursing hours, and then now for the CMA, that we really haven't covered.
That's right. And to go further on Representative Reese's comment, in the memory care living area of the building, there will be no exception. There will always
Right.
be 2 caregivers required
All the time.
in the memory care living area.
Okay, very good. Got it? Okay, Representative Lott, you're recognized.
Madam Chair, at the appropriate time, I'd like to make a motion to pass.
Okay, I'll take this at this time. We have a motion to pass. Do I hear a second? Second. Okay, we got a motion to pass. I think you have a amendment that you want to add to here again.
Right. So I've talked with the department and with you, Chair Cooper, and on line 92. We'd like to add after the word times, at all times. And we've talked to Ledge Council. Okay. She thinks she has an improvement to the original suggestion. Would you like to? All right. I'm going to let her state the amendment.
We were just trying to make it as clean as possible. So, line 92. After all times, comma, which may include 1 registered professional nurse, licensed practical nurse, or certified medication aid. Comma, if they remain on site in the memory care center. And I left off some commas, so let me do it again with
Joe?
the commas. So this was.
So that adds, we did not consolidate the nurses into that statement. That,
Right.
So my reading of that does that. I think that's great.
Okay, so after times on line 92, times, comma, which may include 1 registered professional nurse, comma, licensed practical nurse, comma, or certified medication aid, comma, if they remain on site in the memory care center.
Okay. It's just being very specific that there has to be 2 people before they had to have 2 medication aids. And we just don't need 2 medication aids in the memory care unit or on the floor.
Right, a medication
Anytime.
aid just essentially is
Given
a
passing
certified
out
nurse's
meds.
aid that has a few extra hours of training related to medication administration. And so this is clarifying that the two caregivers in memory care at all times could be two registered nurses, could be two LPNs, or they could be two caregivers with the minimum that have met minimum training requirements, or any combination of those.
But whatever it is, they just don't go below 2 at any time in a memory care unit.
Yep. And I'd like to add, I see the Alzheimer's Association in the
Yeah,
room,
I
and
was
they've been a
fixing
part
to-
of this
I was
discussion
fixing to
too.
call 'em.
So appreciate their support on this as well.
Okay, Nancy. Yeah, come on, you can have a say.
No, I just want to mostly say thank you to Madam Chair for her leadership on this, and there has been a lot of back and forth in the last couple of years, and the advocates have always felt extremely strongly about staffing in the memory care unit, and so this bill still preserves that. It still ensures that for our patients that need the most oversight and the most care, that they're going to get it, and allows some breathing room on the other side. And so thank you for offering it, and really thank you to Madam Chair for being our champion in this issue. So.
Thank you. Tom Bauer? Is he still here?
Just say right here if you want.
Okay.
Leading Tom Bauer, Leading Age Georgia. We have residential facilities, very sized nonprofit sector, and mission driven, and we want to thank you for your compassion for our residents. And we think, this has been discussed for 2 or 3 years, and we think this is a work, and we appreciate everybody's work.
Okay, thank you. Okay, Representative Reese, you had a question about the amendment? No. Okay, no. Okay. Okay, we have, okay, you want to offer a do pass on the amendment? Do I hear a second? Second. Okay, we'll take up the amendment. Everyone in the favor of the amendment, we have a motion and a second to do pass, say aye. Aye. Anyone opposed, no. Okay, the ayes have it. And before I call the bill, I will tell you that the department has been very cooperative, and I appreciate Joe with umpteen phone calls, even late in the evening when it worried me to death about something that came up, with helping us to try to make sure that some of the most vulnerable members of our society get the best care we can possibly give and oversight. And I know that's what most of the providers are trying to do. I'm sorry that if I get old and need to go to one, I won't live in your area where I could come down and be in one of your facilities, although I'd probably drive you crazy. But we do have some bad actors, and as always, bad actors spoil it for everybody. And I know that the department, I believe, is asking for more investigators. Is that correct?
Well, raises so we can
keep them, and so that we can continue to improve the care. So anybody that's out there and that's on appropriations, any of our legislators, please put in that request for us so we can do that. Okay, everyone in favor of House Bill 1335 as amended, and it will travel as a sub, say aye. Aye. Anyone opposed? All right, the ayes have it, and House Bill 1335 as amended, traveling as a sub, will go forward.
Thank you.
And be careful going home. Okay, let's see what we got next. We go to Representative Dempsey. Okay. I stole your pen. Not working. Just mark it out. Ooh, it hurts when I smile.
Thank you, Madam Chairman and members of the committee. This is a measure to help DBHCD. You all may remember that last year we passed in the House HB 520. It is resting in the Senate. You have already voted on each of these measures in that bill, but I want to go over them with you. And we voted them through the Public Health Committee too, as well. So there are 4 changes here, or there are 4 items that are separated here to move forward on if we possibly can. There is a similar bill over in the Senate, but just to make sure, we want to make sure that the House can still continue to lead on this and move forward for mental health and developmental disabilities. It comes from the department. So, if you look in the first section, the amendment aims to address challenges faced by the Behavioral Health Coordinating Council, the BHCC, in achieving a quorum and scheduling meetings. The council plays a vital role in coordinating and improving behavioral health services in Georgia, bringing together various agencies and stakeholders. 1013, also known as the Mental Health Parity Act, expanded the membership to this commission to include more officials and stakeholders. The expanded membership, though, has led to difficulties in scheduling meetings and achieving a quorum. Section 2 seeks to repeal eliminating the requirement for the IDD state plan. The intent of this section was to ensure public awareness of available resources and establish a process for gathering stakeholder input regarding services, accessibility, and program development. Currently, there are also several possible accessible avenues for gathering stakeholder input and are open to the public. The department is mandated to hold public meetings to collect feedback on all intellectual developmental disabilities waiver application proposals and rate studies completed for the waivers. Additionally, there are some of the active councils serve as feedback mechanisms for the department. The list is not exhaustive, but there are several. Behavioral Health Coordinating Council, the Georgia Coalition on Older Adults and Behavioral Health, the Supported Housing Advisory on Residential Experiences, the Statewide Leadership Council, the Advisory Council on Services to Persons with IDD, the Georgia Behavioral Health Planning and Advisory Council, the Intensive Customized Care Coordination Quality Council, the Interagency Directors Team, the Deaf Services Advisory Council, and the Behavioral Health Provider Advisory Council. So there are other ways for that information to be collected. In Section 3, you will see that the licensure for professional counsel, social workers, and marriage and family therapists. This will streamline the licensure process for professionals transferring from other jurisdictions to address the current workforce crisis. Just a little background on this. The licensing requirements have created additional barriers for certain professions in behavioral health particularly. This proposal seeks to align licensure standards across jurisdictions and grant the Georgia Composite Board of Professional Counselors, Social Workers, and Marriage and Family Therapists the authority to issue licenses without mandatory examinations. So just for an example, we know of a licensed professional social worker who moved to Georgia to become a program director at DBHCD. She still wanted to have a part-time clinical practice on the side. She was informed by our state that she still needed an additional 1,500 hours and direct experience, an additional 20 hours of supervision, even after being licensed in Florida and in good standing for 10 years. As a result, she decided not to pursue licensure. She had a full-time job. Here and any other further attaining those additional hours wasn't going to be possible with her work schedule. So it deterred her ability to continue in that way. In Section 4, you'll see the repeal of the annual report for residential treatment facilities. This this component is for the submission of an annual report by the Commissioner of Behavioral Health and Developmental Disabilities regarding residential treatment facilities. The information on in and out-of-state residential treatment and placements for children required here. DBHCD serves portions of these populations. It is not the holder of the data, so it is difficult for them to do this. the consequences of not pursuing this legislation. The repeal may lead to duplicated efforts, as there are already interagency initiatives such as the Behavioral Health Coordinating Council and Multi-Agency Treatment for Children Committee. So some of that should all sound familiar because we have done it before, but it's taking segments of that bill that are really important to try to move forward right now for DBHCD. And to that, before there are questions, I want you to know that if you look at line 38 on the bill, there was an omission of one position, and so we do have an amendment to add that back in, and that would be on line 38, after the first one listed, the Commissioner of Behavioral Health and Developmental Disabilities, it would add the Commissioner of Veterans Service. And they currently serve. Yes. I am.
This was part of 520 that we sent over last week.
It is.
Is that the bill that one of the senators, even though it was 20 pages shorter than the first mental health bill that we sent, told us that it was too long a bill and that we should send over smaller bills? So
Well-
this 3 pages and a 8 is one of those smaller bills that we're sending over
We
to
have
our
definitely made it
colleagues?
smaller, much easier to read. And I will tell you, I do feel that large bills like that with this complex subject matter is difficult
It is.
for, certainly for the public to process as well.
And we have broken it up. I had one yesterday about the loan repayments
Right.
to help get us the psychologists and psychiatrists we need. That was one of the broken out pieces for it. So slowly but surely, we're getting the pieces sent over in smaller chunks.
There were some very important things in that, and we need to try to do it quickly to help them deliver service as well.
Okay, questions for the presenter? No questions? Okay, we got a movement on the bill?
So move.
Okay, so move, second? Got a move and a second. Okay, we have an amendment. You read the amendment. How do you you gonna go up and read the amendment for us?
We
Okay,
have
as
the
she did, it
amendment
was okay?
right there. Amber has the amendment also, and it simply is on line 38.
Oh, she had it?
After the Commissioner of Behavioral Health and Developmental Disabilities, comma, the Commissioner of Veterans Service, comma. And I'm sure that may impact the numbers as it goes forward. I don't know of the lines, but that's the only change. Yeah.
Okay. Anybody, any questions about the amendment? No questions, I have a motion. I've got a motion on the amendment and a second. Is there anybody, do we have anybody who wants to speak to the, no? Nobody? Okay, so no further discussion? All right, everybody in favor of the amendment, say aye. Aye. Anyone opposed? No? Okay, the ayes have it. Now
Thank you.
back to the bill.
Oh, I'm sorry.
Pardon?
I was moving too fast. I was about to step away. Sorry.
Okay.
Yeah.
All right, so we have House Bill 1344 as amended. It'll travel as a sub. Everybody in favor say aye. Aye. Anyone opposed, no? The ayes have it. Thank you.
Thank you.
Very much. Okay, all right. Representative Earhart. This is Bill 844. Huh? Go. Everybody still have 8? 1, 2, 3. Oh, yeah, I'm okay. Don't other people leave.
Good afternoon.
Okay.
I know y'all are ready to get out of here. I'm going to try to make this as brief as possible while still doing justice to the bill. Thank you, Madam Chairman, and hello to members of the committee. I bring to you HB 844 for your consideration, which is a bill to repeal and reenact the Dietetic Practice Act, which was established in Georgia in 1981 and has not been updated since 1994, so 20 years. The new name of the bill is the Practice of Nutrition and Dietetics Act. The reason for the bill and the problem that currently exists is that there is great confusion in our licensure code, and this law would fix that. It's a modernization bill for all intents and purposes, bringing the language, the scope sort of into the 21st century. Someone mentioned earlier with a bill about just the advent of technology and how different things are now. That is no different with this bill, with the advent of telehealth and other technological advances that have been made to aid folks in this field with their practice. The bill incorporates that as well. The language that you see in this bill is a result of a collaboration between the Georgia Academy of Nutrition and Dietetics and the national organization of the same name. This law would do a number of very important things. Number one, provide clear language regarding standards of practice for licensed dietitians and licensed nutritionists. It would narrowly tailor language in the regulation of what's called medical nutrition therapy, which is the highest level of nutrition care that also requires the highest level of training and education and skill. This is necessary to protect consumers. The bill also provides a pathway to licensure for all qualified nutrition professionals, and most importantly, will provide clarity and guidelines for the nutritional services that are allowed for unlicensed individuals like trainers, health coaches, holistic wellness advisors, folks of that nature. I did, if you will, if I may defer, Madam Chair, with your permission, I have Jet Tony here, who has a little bit of historical knowledge on why we got here with this bill and what the changes that have been made to a previous bill that was carried here 2 years ago. So if I'll step up just a moment.
Good afternoon, Madam Chair, members of the committee. 2 years ago, another member of the House brought forward a proposal dealing in this same subject matter. It was put before the House Regulated Industries Committee. The approach was, this is not a negative, but it was clunky. And so Chairman Powell suggested that it would be good to get a bill that is more encompassing and bring it back. Now, that was 2 years ago, and the Georgia Academy, working with the National Academy and other national nutrition organizations, has brought forward to you this substitute that is a remarkable rewrite given what has happened across 20 years. And I'd like to say that I am very proud of my clients for investing the amount of time that it took to get this bill written and perfected, and thanks to Sarah for the many redrafts on this to get here today. Robin Stegall is the Public Policy Committee chair for the Georgia Academy, and she has invested countless hours of her personal time on it.
I want to introduce her as well. And certainly, I believe in this bill. I certainly will also defer to greater minds than mine on the subject matter that delves deep into the issues of dietetics and nutrition. I can give you the basics for sure. But if you will, Madam Chair, I'm just going to allow Robin to have just a moment to kind of share with you her perspective on this bill and why it's so important.
Yes. Before you do that, somebody, are we dealing, I mean, I used to love the school's dietitian, okay? I'm familiar with hospital. They called them, I think they called them all dietitians at the time. You talked about different levels. Somebody just briefly give me a...
Right, and I'm going to let her do it
Okay,
as
let
well,
her do
but
it.
I will
thought
tell
she
you real
might be
quickly,
able to.
you often find the terms used synonymously. There is a difference, there is a distinction, but often those terms have been somewhat interchangeable, but I'm happy to defer to Robin
Okay.
on that. Yeah.
And I get it that we were working this out because of the differences.
Yes, the
And-
differences, and it was a number of things. Some of the modernization language, it's all just been refined. I think we have a far better result now.
And I think part of the confusion for consumers is the fact that, the term nutrition is kicked around a lot, and then we have different arenas in which we're utilizing nutrition care, and it can be in the schools, it can be in hospitals and clinical settings. This bill is specifically seeking to address licensure requirements around the medical setting. For medical nutrition therapy, a simple definition is the provision of nutrition care for the treatment of a disease or condition that's been diagnosed by a medical provider. So this would be like diabetes or hypertension or high cholesterol, that sort of thing.
Okay.
So we're seeking to provide greater avenue for all qualified nutrition providers who can provide the appropriate documentation and show the same standards of education as a dietitian, that they can also apply for licensure. The difference, though, is that because dietetics encompasses a broader scope, slightly broader, we would like to maintain and preserve the title of licensed dietitian nutritionist and not just put everyone in the same bucket. So this bill seeks to provide clarity and give dual pathways for that.
So this is sort of like LPNs and RNs and nurse practitioners.
Similar
So-
but distinct.
Pardon?
Similar but distinct.
That's
in
distinct,
their own
okay.
ways, yes.
Okay.
Well, I would just say that this is I'm a private practice dietitian, and I've been in private practice for 15 years. I see patients from my physicians that refer to me for the provision of medical nutrition therapy. But at the same time, I acknowledge that not every single thing that I do as a dietitian really is at that level of care. Some of it is, general guidance and advice, and there are the education in the field of knowledge around nutrition and the different pathways for people who don't want to become dietitians, that don't want to seek that clinical level of training. Right now, our statute is so vague that there's confusion as to whether or not they can provide care, what level of care that can be. And so what we're seeking to do is really provide the clarification so that people can essentially do the job that they're trained to do.
Okay, thank you.
I just did want to echo that also. If I can direct you even for the non-licensed individuals. It's been a relatively broad definition until now. I believe the entire definition basically encompassing by saying anything that is non-medical, but that is simply not that is simply far too broad. So in terms of the non-licensed professionals, that has to be confined to the areas of prevention and wellness. They, in no way would this advice be given to diagnose a problem or treat a problem, a medical problem that should be handled by a licensed professional. It's important to note also that the bills for a licensed dietitian and a licensed nutritionist both require a master's degree. So it's definitely an elevated level of requirement there.
This would not cover, like I walked in to my husband, who was a GP, believed that zinc strongly could help with healing if somebody was having surgery. And I didn't have surgery, but I was getting some for a friend. And I walked into the store and said, I need help picking out a good bottle of zinc. What kind is the best? And the lady said, oh, I'm a doctor of whatever. Right. And I went, okay, not medical, right? No. And proceeded to show me what she thought the best zinc was. We're not talking about these people in any way.
No. No.
Do we have a name for them?
General non-medical nutrition. I mean, I don't even know how you would describe them. Unlicensed, right? Folks that you see, in health centers or your workout facility, or let's say a personal trainer or a coach. There's really not been a lot of clarification as what they are allowed to advise or not. So the bill does seek to lay that out more specifically. Principles of general non-medical, non-licensed principles of just human nutrition and food preparation. Basic principles of self-care, having a healthy relationship with food, things that are not designed to prescribe or treat a medical condition. And it's just, now we have it. And listen, there are folks that may cross the line because out of pure ignorance, not realizing what they could. Not that there was any nefarious purpose there, not all, I'm sure there were some, but it is outlined now in code. There can be no confusion about when they are or are not crossing the line. Okay. Thank you. Stand for any questions if anyone has any.
Is that it? Okay. Do we want to? Okay, who's 16? Representative Lott.
Thank you, Madam Chair. So I just would like a general kind of a brief overview, because within this legislation we have, and I know you said master's degree, so I was listening, but I don't really fully understand. Licensed dietitian nutritionist, a licensed nutritionist, both are labeled, but they're referring to code sections, so I don't understand completely. And then there was a third, registered dietitian nutritionist. Could you please just explain to me
Right,
some of the
right,
difference
and the
between those
distinction.
three?
And I think part of it has to do with the training, what is involved with the supervised portion of their training, and also the scope of their practice. I'm actually going to lead in here to Robin to kind of clarify that, because I know you're a professional. I want to make sure you get the answer.
That's right, thank you.
Yeah, I think because the bill is kind of meaty, I think it might help to sort of walk through what the actual definitions are. This is where we can kind of, sort of to answer your question. The very beginning section, and I can point you to, it is the definition section. Let me get there. So that's going to be subsection 3. That's where we start with the update and sort of bringing our vocabulary into the 21st century. If you look at line 57, it starts with the definition of dietetics. So fundamentally, when we're asking the question, what is a licensed dietitian nutritionist? A licensed dietitian nutritionist is a provider who is licensed to provide, who is basically a provider who is licensed to practice dietetics. And this definition of dietetics is breaking down in very clear detail all that encompasses. So lines 57 through 93 are covering what it means to be a dietitian. The standards and scope of practice is broken out into this provision, into this definition. A licensed nutritionist, that means that someone who is licensed to provide M&T, they are licensed to provide, they're licensed to practice nutrition. And so the definition for what nutrition is, that begins on line 121 and goes through 148. It's definition 13. I think sort of very generally when we're thinking about it, the distinction between a licensed dietitian nutritionist and a licensed nutritionist is similar to the distinction between an MD and a DO. Medically speaking, both, part of physicians, but they have gone through slightly different pathways to get there. I don't know if that
they
answers.
practice in this state the same.
Right,
And
yes.
will they be able to do the same, just different titles?
Very, very similar. There are, within the code, within the statute, there are slightly different scopes for what a licensed dietitian nutritionist can do and what a licensed dietitian can do.
I also say, Robin, even explained to me originally that if you think of it, that the dietitian is more trained in food and nutrition, you made that distinction, versus the nutritionist trained strictly in the nutrition side, not the food side, if that helps a little bit. As I said, they're very similar, minor distinctions. The other thing was the issue about the supervised training, the supervised portion of their training. That is required, different requirements for the dietitian than the nutritionist.
Okay, which one is trained just in nutrition, and are we talking just in the use of vitamins and minerals and what they do in the body and everything? And the other one is like learning all about food?
So there are very specific distinctions. So briefly, nutrition covers the following divisions: nutrition science, biochemistry, physiology, behavioral science, cellular and systematic metabolism. Dietetics covers all of those, and then it includes nutrigenomics, pharmacology, food science, food systems and management, and social sciences. So all dietitians are nutritionists, but not all nutritionists are dietitians. So the scope of the dietetic training is, the depth and breadth of our training is a little bit larger, which means that we have more fields that we are practicing in, and a broader scope for practice versus a nutritionist. They're very, very similar, and the bill is trying to make those distinctions in terms of what level of care that they can provide. I think your example around nursing, about an RN, an LPN, that kind of thing.
Okay, levels.
Right. As opposed to everyone is licensed and they're all still called licensed dietitian nutritionists. We're still trying to maintain that distinction between the slightly higher level of education and training that a dietitian receives.
Okay, is there agreement to this with these people? Have they agreed?
Yes. They are agreed that both the Georgia and the national, they were highly involved in the development of the bill. We have had no opposition. Secretary of State's office is aware, and fine. Okay. No opposition from them.
No. Okay.
Madam Chair, I do
Okay,
If that's okay.
fine.
All right, so this just plays on something that was either last year or the year before, and it's just a question, and I don't know that it's in here necessarily, but this is, of course, what I'm asking. But, so you referenced the gym, and you see in here in nutrition, it talks about goals, weight loss goals and that sort of thing. So as long as they are not advertising themselves to be dietitians or nutritionists specifically, this does not in any way prohibit folks from creating plans with a gym member as they work through their fitness and their food goals to attain weight loss and
That is correct,
health
as
improvement.
long as that plan is of a generalized health nature and not designed, again, to treat any medical condition. You touched on something else that I did want to mention that's also included in the bill, and that is protections for those who are licensed, meaning if you are not a licensed dietitian or a licensed nutritionist, you cannot advertise, you can't hang out your shingle and call yourself that.
I think that's right. Thank you so much.
What else? Okay, other questions for the committee? Okay. I don't think. Okay, you're pretty specific on spelling out the exceptions. Okay. No other questions from the committee? I think that we don't know enough about the differences between nutritionists. It may say something about us. Is there anybody that would like to speak to the bill? Really? Okay, that's all right. Okay. So what's the will of the committee? Move to pass. Do I have a second?
Second.
Okay, we've got a second and a do pass. For do pass. So anybody else want to say anything? And I've already asked the committee. All right, everybody in the favor of the passage of the substitute to House Bill 844, say aye.
Aye.
Anyone opposed, no? Okay, the ayes have it, so you've got it.
Thank you, Madam Chair, and thank you, committee.
No wonder it took so long to get it out and get it together. Okay, did you call him? Okay, we have one more. Let's see if we can move. We have to get the person here. Oh, yeah, and it needs, I mean, it's. How many people are here to speak about this next bill? Oh, I know, Jess. Cash is here for the bill. Pardon? What'd you say, Cash?
He's at your service.
Go to the room. here to listen to the next bill? I really am gonna have a hearing only. If we don't hear it today, you miss a hearing, which means there will not be a vote on it. It won't move this year. Will you be okay with that? I know the people from the insurance companies are okay with it. I'm just trying to see if there's anybody. Pardon? Well, don't faint, but this time I'm actually on their side. Than nice and accommodating for us to get these bills out for other people, important bills, and the fact that we were just gonna listen to this one.
We were just gonna hear it.
No, yeah, we were just gonna hear it. It got really expanded from what the concept was to what appeared on paper. And, so I will tell him he needs to work on it over the summer. And, I do think that there is a place for mothers who've had to have both breasts removed because of cancer, that perhaps we can do something. And I know I have somebody in the audience that doesn't agree with me, well, almost, because we have I'm picking on Mary Lee, because when I explained to her that I thought that, maybe we could do something about paying for breast milk. Apparently we still have, we don't have a big abundance of breast milk because we don't have a breast bank. So I think one of the things we need to talk about is having a breast bank, like all the states around us have a breast bank for breast milk.
A human milk bank.
Is that what it's called? A human milk bank. We do not have a human milk bank. Sorry, guys. But not. I don't think so. I don't know where they're getting it. Do the hospitals have them, Mary Lee?
It gets shipped in from other states.
Oh.
It has to be pasteurized. Yes.
Okay. Mary Lee, step up for a minute. We'll have a discussion here just for a second. Okay. Mary Lee, first of all, is my friend. Secondly, she's an attorney, a registered nurse, and was married to an OBGYN, is married to an OBGYN, and practiced in that area of medicine for a long time, is very concerned about what happens to our mothers and babies across the state. A great advocate, served on the Maternal Mortality Commission for years, and I don't know what else, just a great human resource on medical issues. Mary Lee.
Thank you.
You're welcome.
Yes, so Georgia does not have a human milk bank.
A human milk bank.
We have lots of issues in helping our mothers be successful at breastfeeding, and we need to be able to help these mothers successfully breastfeed because but as Representative Cooper said, there are situations where mothers are not at all going to be able to breastfeed, whether it's because of surgery or certain medical conditions. And so for those situations, yes, it would be great if we could provide those babies with human milk. We don't have enough human milk across this country to feed full-term healthy babies. Right now, that human milk is primarily reserved for NICU babies who really medically need that milk in order to avert situations like necrotizing enterocolitis.
Which is fatal, usually.
Which can be fatal, right. So our NICU babies need that human milk right now. Now, if we were to be able to license our clinical lactation consultants in this state to help our mothers be successful at breastfeeding, that would be extremely helpful because we know that with the help of a clinician, many mothers can be successful. And so I really have mixed emotions about providing formula, which is a bovine product. It's not a human milk product. to these babies when if we could provide these mothers with assistance, with proper clinical assistance, we could help many of these moms be successful who fail.
So, but would it be helpful even where we are if we had a human?
If we had a human milk bank, that would be great.
You think more mothers that are able to have extra milk would participate?
Yes, I think that would help us get more mothers to donate their excess breast milk, for sure.
And if we wrote a bill or encouraged Representative Kelly to write a bill, it really be, if we're going to use and ask the insurance companies to pay for it, we should ask for breast milk, human milk, if they were preemies first, and only if there was excess milk, available or something.
Well,
if they were
preemies,
full-term babies, or they don't need the breast milk if they're full-term babies as much.
I don't know what happened. Okay, so preemie babies really benefit the most from donor human milk because of their risk of necrotizing enterocolitis. But we have other babies who end up in NICU with other medical conditions that also would greatly benefit from human milk. Every baby benefits from human milk over bovine milk. Okay. It's much healthier for every single baby. And if we had excessive human milk across the country, that would be the gold standard. Let's give every human baby human milk, because the antibodies that are in that human milk help those babies thrive and survive. When you pasteurize human milk, you lose a lot of that benefit. You still retain the benefit for those NICU babies to avert NEC, but you don't get the immunity properties and a lot of the other active DNA. All of that is killed off with pasteurization. So really, really, to help our moms and babies across this state, we need to be clinically helping mothers to provide their own milk, to help them be able to produce that milk for their own babies. And without clinical assistance, there are lots of mothers who are not successful at doing that.
One question, Representative Washburn.
Thank you. This is quite interesting to me. My wife and I had 4 children, and she breastfed them all and was highly successful. They all thrived and flourished. I'm curious about the human milk bank. What is the shelf life of human milk, or is it frozen? How is that kept?
I'm not sure exactly what the criteria is at the human milk banks. I do know that for mothers who produce their own milk at home and keep it, I believe they say no longer than 6 months. You can freeze it and then thaw it and use it.
But the pasteurization process damages the human milk?
It absolutely damages all those great DNA and antibodies, and so much of the benefit of human milk is removed with pasteurization. But it's still better for a preemie baby to be able to get human milk versus bovine milk, because those preemie babies are not always able to digest the bovine products, and it will go into the gut and won't be absorbed, and it'll set the intestines up for necrotizing enterocolitis, which is gangrene of the intestines. So babies can get sepsis and die from that.
Okay, we got another question. Representative Lott.
Yes, ma'am. I just wanted to say, so I just looked it up because I knew that I had had these conversations, but I do know that in Augusta our NICUs do have the milk labs, and they have, so the Medical College of Georgia has a doctor there and they have started a scanning process to make sure, they use scan codes now on all of that breast milk, and that's something that we have been doing. And I do know that the Medical College of Georgia, the dietitian, which I don't even know if that's just her title anymore, but that's where she started, travels the country to create these milk labs in other NICUs. So I'm pretty sure we do have that. Yeah,
and the milk labs are taking in that baby's mother's own milk. So they're not pasteurizing that milk, but they are collecting it from the mother and are storing it for use for that particular baby.
Yes, correct. Because she was referring to the NICUs, and I just wanted to make it clear that we are doing that, and I would imagine you're doing that all throughout Atlanta and the rest of the state, I would hope.
Wasted this discussion or about Kelly, because it sounds like to me, will you give me the name of that person that works it? So as we talk and go forward, if we talk about a human, whatever it is.
Human milk bank.
Human milk bank, that we can talk to her and see what, she would know all the particulars about it.
Yeah.
Okay, thank you, Mary Lee.
Yep.
Thank you. Okay, we've been adjourned. I noticed that Representative Earhart's still hanging at the door. Just stay over here. You'll be amazed at what all we talk about. Come on up and get the paper signed. I'm sorry. You should have come on up around the